Hello, my name is Jason Edwards. I'm a fourth year medical student at the University of Buffalo, and today I'm going to be presenting a case of a patient that has a suspected thoracic outlet syndrome. So the format of my case today is I'm going to go over the patient in detail, and at the end of that, in the discussion, I'm then going to compare and contrast thoracic outlet syndrome with cervical radiculopathy to give the audience a better sense of what we're looking for in diagnosing the two and what we're looking for when those two things are paired against each other in the diagnosis. So let me first start off with the HPI of the patient in question. So this is Mr. T. Mr. T is a 52-year-old African-American male with a past medical history significant for a prior motor vehicle accident, hypertension, hyperlipidemia, and scoliosis, with a recent MVA on 7/17/2015. He reports the accident occurred as a belted driver of a moving vehicle that was hit on the front passenger side of another vehicle. Upon impact, he reports a whiplash event as his body went forward and backwards rapidly. Per the patient, he reports to bracing himself against the steering wheel upon impact. Patient denies loss of consciousness, airbag deployment, or blood loss. No ambulance was called on the scene. The day after the collision, he was treated at urgent care facilities. He was examined and prescribed naproxen and Roboxen. In the office today, the patient reports neck pain that radiates down both the upper and lower extremities and predominantly into the fourth and fifth digits of the upper extremities bilaterally. There is an associated numbness in the aforementioned digits. The pain is specifically associated with the MVVA on 7/17/2015. As he states, he did not have the symptomatology prior to the collision. Patient also reports associated headaches on the left temporal region. The headaches noted are constant with ongoing changes in intensity. The patient reports to baseline pain that is 3 out of 10, with increasing at times to 9 out of 10. The pain is described as stabbing in the left temporal region. The pain has no associated temporal relationship, and the patient cannot cite any aggravating factors. He does state that drinking alcohol alleviates the pain. Patient reports the neck pain to be constant. The focal point of the neck pain is the center of the neck. The pain is currently a 6 out of 10, but can rise at times to 8 out of 10. No temporal relationship is described. Patient does not cite any aggravating or alleviating factors associated with this pain. There's numbness and pain that the patient classifies as a 4 out of 10 bilaterally in his fourth and fifth digits of his hand. There is also intermittent numbness in the left thigh radiating to the left foot. As per review of systems, for constitutional symptoms, the patient is positive for headache, denies nausea, vomiting, blurred or double vision, lymphadenopathy, recent illness, fever, chills, weight gain or loss. Skin, he denies rash, itching, or dryness. HEENT, he denies tinnitus, oral ulcers, sore throat, congestion. Cardiovascular, he denies things such as chest pain, edema, claudication. With his GI exam, he denies any abdominal, nausea, vomiting, or changes in stool. And then for musculoskeletal, as mentioned before, he is positive for neck pain, hand pain, thigh pain, numbness bilaterally in the fourth and fifth digits. And for his neuro exam, he's positive for weakness in the neck and hands and denies headaches. And admits headaches. I'm sorry about that. As for past medical history, it's significant for hypertension, asthma, prior motor vehicle accidents, depression, hypertension, hyperlipidemia, insomnia, scoliosis, arthritis. He has no known drug allergies. For his past social history, he's significant for his past surgical history. He's significant for corrective surgery for his scoliosis. For his social history, the patient is currently working as a handyman and lives at home by himself. The patient drinks approximately 1 pint of whiskey per day. The patient denies smoking cigarettes, and he also admits to smoking marijuana a few times per week. Per his family history, the father is deceased. He has a history of colon cancer and hypertension. The mother is also deceased and has a history of Alzheimer's and hypertension. So getting into the physical exam, this is where we can really differentiate thoracic outlet syndrome from other diagnoses that are possible, such as cervical radiculopathy, that we will talk about further in the discussion. For his general appearance, he is alert and oriented times 4. He's in no acute distress. He's appropriately dressed and appears a stated age. His HEENT review is normal cephalic, atraumatic, and perla. Cardiovascular, he's S1 and S2 are appreciated. There's no murmurs, rubs, or gallops. His pulses are 2 plus in bilateral extremities. For his lungs, they're clear to auscultation bilaterally. There's no wheezing, rhonchi, or rales. No extramuscular involvement with inspiration. His neuroexam, his cranial nerves 2 through 12 are intact. His reflexes are 2 out of 4 in the biceps, triceps, and brachioradialis bilaterally. In his musculoskeletal exam, his range of motion in the cervical spine revealed flexion to be 32 out of 50 degrees, rotation to the left 40 out of 80 degrees, right rotation 30 out of 80 degrees, left lateral bending 32 to 45 degrees, right lateral bending 19 to 45 degrees, extension to 18 out of 60 degrees, extension. Cervico-thoracic pain noted during forward flexion. The patient reports right-sided neck pain during left and right lateral bending, reported left-sided neck pain during left rotation and right-sided neck pain during right rotation. Cervical compression testing produced reported neck pain that radiated to the left shoulder during left rotation and right rotation cervical compression on testing. Extensive cervical compression testing revealed elicited cervicothoracic pain and anterior upper chest pain, which he has likened to be concerned about his heart in the past. Active range of motion in the shoulders revealed each could be elevated to 150 degrees approximately. Muscle strength of the upper extremities revealed left bicep to be weak, graded 4 out of 5. Bilateral finger extension extensor weakness was noted and graded 4 out of 5 as well. Grip strength tested using a jammer dynamometer revealed his right hand to have 50 pounds of strength and his left hand to have 40 pounds of grip strength. He reports to being right hand dominant. Wright's procedure was performed on either side and such was negative with no diminution of pulse. The costoclavicular procedure was, when performed on either side, reproduced numbness into the fourth and fifth digits on ipsilateral sides. Follow-up tests with the digital palpation and a compressive matter beneath the clavicle bilateral and such did not reproduce his symptomatology of numbness in the fourth to fifth digits. With contralateral head rotation, ipsilateral left and right numbness into the fourth and fifth digits was reproduced when such tests and additional diminution of the pulse was noted. Rue's test was positive bilaterally for numbness into the fourth and fifth digits bilaterally. The patient has had several imaging studies since his MVA, his most recent MVA. We will go into depth about his MRI of his cervical spine, but first I'd like to mention a couple other studies that have been conducted since then. He had an X-ray of the ribs left with PA chest, 9/12 of 2015, and those showed no acute signs of pulmonary disease no evidence of rib fractures or pneumothorax. He had an upper extremity NCS and slash needle EMG, and those showed no electrophysical radiological evidence of cervical radiculopathy, focal upper extremity entrapment, neuropathy, brachial plexopathy, or peripheral polyneuropathy was observed in those studies. This does display MRI evidence of cervical disc pathology with C6 and C7 foraminal narrowing. However, this should not be causing his C8 ulnar symptomatology. Additionally, patient lacks specific neurological deficits such as diminished reflexes or muscle weakness, which is typically expected in radiculopathy. One consideration given his history of cervical spine acceleration and deceleration injuries would be the possible bilateral thoracic outlet syndromes that we are suspecting. And this is all per the needle EMG upper extremity NCS studies. This is all per the report. So now we'll go into depth about the MRI of the cervical spine that the patient had on 2/23 of 2016. Okay, the moment you've all been waiting for, the MRI of the cervical spine, which was done on 2/23/2016. His clinical indications for the test was an MVA, as stated on 7/17/2015 with associated neck pain. For a comparison study, there was an MRI of the cervical spine on 2/19/2014. His image sequences were multiplanar multi-sequences. Images of the cervical spine are obtained, including flexion and extension images. So the findings. At the level of C2, C3 level, there is a focal posterior disc herniation, central stenosis, or foraminal narrowing. There's none of those things. And you can see on the imaging displayed that most of his pathology looks normal. At the C3, C4 level, there is a disc bulge with effacement of the anterior CSF. Spinal cord is not deformed. There is at least mild foraminal narrowing bilaterally, right greater than the left. This appears more prominent on the left. Overall findings are relatively stable. At the C4, C5 level, there is a posterior disc protrusion herniation, which is in contrast with and deforms the spinal cord with at least mild to moderate central stenosis. There's mild foraminal narrowing that is seen bilaterally greater on the left than on the right, which remains relatively stable. There is posterior subluxation. There is some loss of the disc space height. At the C6, C5, C6 level, there is a posterior subluxation, which accentuates the posterior disc protrusion herniation. The disc is in contact with and does deform the spinal cord. There is loss of disc base height and posterior subluxation. Bilateral foraminal narrowing is seen with at least moderate to severe findings. At the C6, C7 level, there is loss of the disc's space height with posterior subluxation. There is posterior disc osteophyte complex with effacement of the anterior CSF. The spinal cord is not deformed. There is at least mild left foraminal narrowing present. Finding remain relatively stable. At the C7 T1 level, there is no focal posterior herniation, central stenosis, or foraminal narrowing. There is motion present at multiple images which does not decrease the anatomical detail. There is apparent absence of the right lobe of the thyroid gland. Correlation with history is suggested. If needed, thyroid ultrasound could be performed. Posterior subluxation is seen in the C5, C6, and C6, C7 levels, which remains relatively stable on the flexion and extension images. So for the impression, we have disc pathology seen from the C4, C3, C4 to the C6, C7 levels. Overall findings remain relatively stable compared to the prior exams. For number 2 of the impression, posterior subluxation at the C5, C6, and C4, C5 levels, which remain relatively stable on the flexion and extension images. For our third finding, these findings are consistent with phase 2 pathophysiology of the chiropractic clinical diagnosis of vertebral subluxation complex. Clinical correlation is recommended. And if further evaluation of radicular symptoms or foraminal pathology is required, correlation with an EMG or nerve conduction studies would be helpful. And as we noted in the imaging, we did actually do the EMG, NCS, and those were negative as well. For the differential diagnosis, in this case we are most interested in the symptomatology producing the bilateral arm and hand numbness, weakness, and pain. Based on the symptomatology present, the fact that the correlation of the symptoms can be linked to the MVA, and that the presence of the positive tests discussed on physical exam that we did, our most likely differential would be thoracic outlet syndrome. Other possible diagnoses worth considering on our differential diagnosis include acromioclavicular joint injury, brachial plexus injury, cervical disc injuries, cervical discogenic pain syndrome, cervical radiculopathy, clavicle fractures, elbow and forearm overuse injuries, shoulder impingement syndrome, thoracic disc injuries, thoracic discogenic pain syndrome. As for our diagnosis of this patient, the main one we're considering today is thoracic outlet syndrome. Also has a prior history of arthritis, hyperlipidemia, hypertension, insomnia, alcohol dependence, neuropathy, and scoliosis. Okay, so let's talk about follow-up. This patient will continue to follow up with his chiropractor and primary care doctor, and will be monitored for improvement of his suspected thoracic outlet syndrome. The standard of care for thoracic outlet syndrome is a trial of non-operative conservative management. A trial of conservative management should be attempted before surgical options are explored. It is thought that 2 to 3 years of conservative management is appropriate. Physical therapy should be initially explored for a period of at least 4 to 6 weeks. Exercise strengthens the muscles that surround the shoulder, and postural exercises help the patient sit and stand straighter, potentially lessening pressure on the neurovascular structures composed of the thoracic outlet. Other conservative measures include passage of time and weight reduction. Medical therapy can be employed considering interscalene injections, anesthetic agents, steroids, or botulinum toxin type A. Surgical intervention should be explored if no progress is made after a trial of conservative management. But as of now, this patient should be referred to a physical therapist for more work in strength and conditioning training. So let's just, for our discussion, briefly talk about the physical exam, considering it's so important to the diagnosis of this. Imaging can often be negative, and our physical exam is a lot of times the best way to make this diagnosis. So there's a certain subtleness about the presentation of thoracic outlet syndrome that makes diagnosing the condition difficult and tedious task. A cautious and mindful physical exam when considering TOS is key to diagnosis. TOS is being considered. There are specific tests that can be performed to confirm our suspicions. So a majority of patients that present with thoracic outlet syndrome show scapular ptosis and atrophy of the ipsilateral trapezius muscles. Downward pressure on the ptotic scapula often reproduced parenthesis in the hand and arm, confirming the postural causation. Weakness of the trapezius may occur from trauma or traction injury to the spinal accessory nerve, or some distal upper limb problem causing the shoulder to be immobilized. All of the above may create postural ptosis, resulting in compression by pulling the nerves and vessels down onto the first rib, causing compression that would elicit the symptoms. Provocative tests used to help diagnose the condition can be crucial. These includes the right test. In the right test, which we performed in our physical examination, the patient's right arm is raised in varying degrees of elevation above the level of the shoulder. The costoclavicular test is another test that is valuable in the diagnosis of thoracic outlet syndrome. In this test, the patient brings the shoulder back in an exaggerated posture. In the overhead exercise test, the patient holds the arms up and flexes rapidly and extends the fingers for 30 seconds. The Atson test can obliterate a pulse or reproduce the abnormality by assuming differential positions. For Wright's test and the costoclavicular test that was mentioned before, for a test to be considered positive, the patient must state that the symptoms have been reduplicated in these tests. Symptomatologies can include paresthesias, or pain and cramping in the limb. The overhead exercise test requires a complaint of cramping or fatigue to be considered significant. The association of typical symptoms of thoracic outlet syndrome with at least one and preferably two of the provocative tests positive leads to the probability of the condition. Manual muscle testing may reveal subtle deficits. In more severe cases, frank weakness and interossei and hypothenar muscles and less in the flexor profundi of the little and ring fingers are noted. Electrophysiological evaluation is indicated in anyone with suspected neurological causes of thoracic outlet syndrome, although the majority of patients test negative for these tests in neurological thoracic outlet syndrome. And that was the case in our patient when we did when we elicited the electrophysiological evaluation for this patient. It was negative. When positive, the electrophysiological signature of the neurogenic thoracic outlet syndrome is quite specific, though not sensitive. As in the case of our patient, EMG testing was negative and thus inconclusive. So now we'll take a few minutes to compare thoracic outlet syndrome to cervical radiculopathy to get a better feel of the distinction between the two diagnoses. And in this, we'll talk about the definitions of both, pathophysiology, the risk factors, the demographics, the radiology, the prognosis and treatment of each of these disorders. So let's start by defining our syndromes. So thoracic outlet syndrome constitutes a group of signs and symptoms that present when a component of the neurovascular bundle is compressed by one of the many surrounding structures. Structures that can impinge on the neurovascular bundle consisting of the subclavian artery, the subclavian vein, and the brachial plexus include adjacent muscles, ribs, and bony structures. Several names are synonymous with thoracic outlet syndrome. Often these names describe specific pathology presented impinging on the thoracic outlet. Those names include cervical rib syndrome, scalene annulus syndrome, costoclavicular syndrome, scalene annulus, and a hyperabduction syndrome. Each name hints at the specific pathology presented. The term thoracic outlet syndrome is used as a catch-all to collectively encompass the wide spectrum of syndromes related to the general region of thoracic outlet syndrome. Each syndrome will be talked about specifically as the parts to follow. When defining cervical radiculopathy, it is commonly referred to as a pinched nerve. It occurs when a cervical nerve in the neck is either compressed or irritated at the level of the nerve root exiting the foramina. The causes of radiculopathy can be divided into compressive and non-compressive etiologies. Most radiculopathies arise from the nerve root compression. Two prominent mechanisms of compressive cervical radiculopathy are cervical spondylosis and disc herniation. Although compressive radiculopathy is by far more common, non-compressive etiologies should always be ruled out in the differential. Let's discuss the pathophysiology of each condition. Thoracic outlet syndrome, in order to understand the mechanism of it, it's necessary to grasp the anatomy of the thoracic outlet. So, the outlet is bounded by bony structures including the spinal column, the first rib, and the sternum. The outlet refers to the space confined between the clavicle and the first rib. The brachial plexus and the subclavian artery emerge between the anterior and middle scalene muscles, while the subclavian vein exits anterior to the anterior scalene. All three structures pass through the space between the clavicle and the first rib, an area referred to as the costoclavicular space. The most commonly involved space for the brachial plexus involvement in the thoracic outlet syndrome is the scalene triangle. Another area of the neurovascular compression is the pectoralis minor space, which refers to the space between the pectoralis minus muscle anteriorly and the chest wall posteriorly. Compression of the bundle as it transverses these spaces can result from developmental abnormalities, injuries, and physical activities that predispose to neurovascular compression. Variations in bony and muscular anatomy often play a role in thoracic outlet syndrome. Specific pathogenesis processes commonly seen in thoracic outlet syndrome include the following. So you can have anomalous ribs, which refer to cervical ribs first described in the 18th century, classified into four subtypes based on length and union with the first rib. In patients with thoracic outlet syndrome, a higher incidence of bony abnormalities such as this is often noted. Congenital cervical fibrocartilaginous bands associated with incomplete cervical ribs have also been associated with thoracic outlet syndrome. Usually this abnormality consists of a radiolucent band that extends from the tip of the cervical rib to the first cervical rib and compresses the proximal lower trunk of the brachial plexus. You can also have muscular abnormalities, which can narrow the space between the anterior and middle scalene muscles. These abnormalities include variable insertions of the muscles, which can lead to overlap and narrow the space of the outlet. Supernumerary scalene muscles can be seen as well. Complete fusion of the anterior and middle scalene muscles can occur. Cervical fibrocartilaginous bands may be present. Subclavius muscle variations can also predispose a patient to thoracic outlet syndrome. Hypertrophy of the scalene, subclavius, pectoralis minor, all these things can also impinge on the neurovascular bundle. Also, injury can cause our condition, including chronic inflammatory change due to trauma, which is the most common etiology of acquired variant anatomy. Neurogenic thoracic outlet syndrome is often due to hyperextension or hyperflexion injury of the neck, which can occur during MVA. Sounds like our patient. Bony fractures of the first rib or clavicle are common mechanisms as well. Repetitive neck movement, overhead arm movement, athletic arm movements, all these can lead to any of the three types of thoracic outlet syndromes noted. For cervical radiculopathy, as mentioned above, it can be divided into compressive and non-compressive pathophysiology. The majority of radiculopathy arise from neuroroot compression, usually caused by either cervical spondylosis or disc herniation. Spondylosis is a Greek word for vertebra and is generally a term for nonspecific degenerative changes of the spine. Degenerative changes can occur in the vertebral disc, the zygapophyseal and unconvertible joints, and the vertebral bodies, leading to bone formation in these areas, which is called the osteophyte or hard disc. These changes can lead to neural foraminal narrowing, compression of the nerve roots, and radicular symptoms. The pathophysiology of spondylosis is not completely understood. One theory states that the sequence of degenerative changes seen in spondylosis begin with the desiccation of the vertebral discs, which is estimated to be 90% water in early adult life, but was only 69% water in the 8th decade of life. As the disc loses water content, the height of the disc decreases and the annulus fibrosus is weakened, leading to increased stress at the joints and end plates. Increased stress is hypothesized to lead to osseous and ligamentous hypertrophy and osteophyte formation. Disc herniation is another common cause of compressive radiculopathy. The intervertebral disc is composed of a ligamentous outer annulus and a gelatinous inner nucleus propulsus. The combination of intervertebral pressure and degeneration of the ligamentous fibers can lead to a tear in the annulus, allowing the nucleus propulsus to prolapse through the annulus. Inflammation and radicular symptoms may ensue if the prolapse material presses on the nerve root. Disc herniation is the most likely result of in root compression and radicular symptoms if it occurs in the directions of the nerve roots. Some causes of non-compressive radiculopathy include infectious processes such as herpes zoster and Lyme disease, neural root infarctions, root avulsion, infiltration by tumor, infiltration by granulomatous tissue, and demyelination. Non-compressive radiculopathies tend to affect the ventral and dorsal root more diffusely than compressive etiologies. Now let's talk about some of our risk factors. For thoracic outlet syndromes, these include sleep disorders, tumors or large lymph nodes in the upper chest or underarm areas, stress or depression, participating in sports that involve repetitive arm and shoulder movements such as baseball, swimming, golf, volleyball, and others, repetitive injuries from carrying heavy shoulder loads, injury to the neck or back, including whiplash, often occur through the means of MVA, poor posture, or weightlifting. Risk factors for cervical radiculopathy include wear and tear changes that occur in the spine with age. Arthritis tends to be a prominent player in the development of cervical radiculopathy in the elderly. In younger people, it is most common caused by sudden injuries that result in a herniated disc. Other factors include jobs that involve repetitive neck motions, awkward positioning, or a lot of overhead work that puts stress on your neck, previous neck injuries, genetic factors, and smoking. So let's talk about the demographics of both syndromes. For thoracic outlet syndrome, there's wide variability of symptoms and signs in patients with thoracic outlet syndrome, and the lack of objective confirmatory tests for the diagnosis makes correctly identifying patients with thoracic outlet syndrome difficult. Therefore, determining the exact incidence remains elusive. It's estimated that it ranges from 3 to 80 cases per 1,000 people in the population. Thoracic outlet syndrome is more common in women, particularly those with poor muscular development, poor posture, or both. Cervical radiculopathy is a common cause of both acute and chronic neck pain. The mean age of diagnosis is 47.9 years, with a range from 13 to 91 years of age. Average annular incident rates per 100,000 people for men and women were 107.3 and 63 respectively. The male to female ratio is 1.7. Age-specific incidence rates per 100,000 people were highest for the 50 to 54 year age group, 245.1 in males and 164.5 in females, and declined steeply after the age of 60. Lower cervical roots, particularly C7, are more frequently affected by compression than high cervical roots. Let's talk about pertinent radiology for both syndromes. So for thoracic outlet syndrome, plain radiography is indicated to exclude an underlying bony abnormality. Image with ultrasound, contrast enhancement, CT, MRI, conventional angiography is useful for detecting vascular compression. Imaging is performed when the patient's arms are both in the raised and neutral position for comparison. Imaging may show the vascular stenosis and complications such as thrombosis, false aneurysm, and distal emboli. Imaging of the bones and soft tissues may reveal the cause. MR angiography with dynamic positioning is particularly useful in the diagnosis of vascular subtypes of TOS. MR imaging also allows for good analysis of the brachial plexus thanks to an excellent soft tissue contrast that it provides. The criteria used for determining the presence of neurological compression are disappearance of the fat surrounding the brachial plexus and close contact with some adjacent bony structures. Neurological compressions seem to occur in the same frequency in the interscalene triangle as in the costoclavicular space. MRI imaging is also an efficient technique when searching for muscle hypertrophy, subclavius, abnormal muscles, and fibrous bands. Ultrasonography has an advantage of enabling assessment of blood flow during performance of clinical tests used in clinical practice. This technique is frequently used to confirm the clinical suspicion of arterial thoracic outlet syndrome. The main advantage of this technique is the direct comparison between dynamically induced symptoms and concomitant visualization of the vessels. Other fundamental advantages of sonography is the possibility of performing the examination when the patient is in an upright or seated position, as in clinical examination, in contrast to CT and MR imaging, which are performed with the patient in a supine position. Sonography also allows the delineation of the brachial plexus structures. With cervical radiculopathy, imaging evaluation revealing evidence of degenerative changes or disc herniation can only support the diagnosis of cervical radiculopathy and not by itself establish a diagnosis. Imaging studies of the cervical spine are usually abnormal in the patient with compressive radiculopathy and often normal in a patient with non-compressive type radiculopathy. MRI is currently the study of choice in most patients for the initial neuroimaging evaluation of the cervical spine due to the ability to visualize soft tissue structures compared to CT. MRI may underestimate the amount of bony abnormalities. T2 sequences are generally more useful than T1 sequences. CT has been the traditional gold standard for the diagnosis of foraminal compression. CT remains superior to MRI in the distinction of osteophyte from soft tissue material. Plain radiographs of the cervical spine are rarely diagnostic in the settings of non-traumatic cervical radiculopathy, mainly because radicular symptoms are usually due to the impingement of a nerve root by soft tissues, and soft tissues are not well visualized by plain radiographs. Diagnosis of radiculopathy is usually confirmed by needle EMG, an upper extremity electrodiagnostic study consisting of the nerve conduction studies and needle EMG examination of the muscles of the upper arm and neck. Since we talked about the treatment of thoracic outlet syndrome starting with non-operative conservative management in our discussion, I'll just skip to if 2 to 3 years of conservative management fails and the persistence of symptoms and failure to respond to conservative management happens, it's might be time to explore surgical options. Good indications for surgical interventions include neurological findings or evidence of vascular compromise. If you do pursue the surgical removal of the middle, uh, if, if you do pursue surgical alleviation of the syndrome, oftentimes the middle 3/4 of the first rib uh, being removed is an effective treatment. This procedure allows for adequate passage of the neurovascular bundle. Resection of the anterior scalene with elimination of present fibrous bands causing compression is another surgical method often employed. The conservative management is effective approximately 80 to 90% of cases, and then the surgical approach has a much more variable outcome in between 27 and 80% of the time it is effective. For cervical radiculopathy, it is important to note that the majority of patients with cervical radiculopathy get better over time and do not need treatment. For some patients, the pain goes away and relatively quickly it goes away. For others, it may take a longer time. It is also common for cervical radiculopathy pain that has improved at one time to return at some point in the future. Even when this occurs, it usually gets better even without specific treatment. In some cases, when it does not improve, however, these patients require evaluation and treatment. Initial treatment of CR is non-surgical. Non-surgical options include soft cervical collar, physical therapy, and medications including NSAIDs or oral corticosteroids, steroids injections, and if retractable to the options above, narcotics. But it is worth noting that narcotic medications are reserved for patients with severe pain that is not relieved by other options. If after a period of time non-surgical treatment does not relieve your symptoms, surgery may be recommended to decompress the affected areas.